My name is Mark Abell. I'm a family physician. I've had a long career in academic family medicine, editing medical journals and doing research. I've been with AFP since about 2002 when J.C. Wick asked me to be deputy editor for evidence-based medicine, and I've been doing that ever since. Yeah, so I trained at the University of Michigan Medical Center, which is a huge place, and there's always experts every time you turn a corner, and it's easy to get your questions answered or at least get an opinion. And my first job after leaving training was to be the only doctor in a rural Georgia county, Madison County, which is near Athens, Georgia, where we now live. And so all of a sudden I had to answer these questions myself, and learning how to ask and answer questions was one part of that journey. Another part was that I was in a federally qualified health center where my patients often didn't have insurance. And so were those brand new, fancy new antihypertensives like calcium channel blockers and ACE inhibitors, were they better than the old standbys? And that was a question I had and had difficulty answering. And then I also saw in the hospital, like the cardiologists were giving patients post-MI calcium channel blockers. And we were taught in Ann Arbor, don't do that. And so, are patients different down here, or is just the way they look at the evidence different? So that and it was around that time that the first articles were being published by David Eddy, David Sackett, the group out of McMaster, and that really resonated with me in that role. I think what I'm most proud of is having helped to establish poems along with Dave Slauson and Ellen Shaughnessy and disseminate that evidence to family physicians and in many different countries, and developing Essential Evidence Plus as a platform for evidence-based primary care practice. I'm also proud of having been a Fulbrighter in Ireland, and serving on the USPSTF was quite an honor as well. Yeah, so I think a big part of evidence-based practice is learning to trust the science and trust the studies, even if it seems to conflict with your intuition or your beliefs or what you know about the pathophysiology. There's a great article by Barry Kramer and Jen Crosswell called The Clash of Science and Intuition. And they talk about this concept of overdiagnosis in cancer screening. And I think concepts like that can be very hard for patients and doctors to grasp. It's so ingrained in us that every cancer is always harmful and that all information is useful. For example, there have been a bunch of studies showing that for patients with type 2 diabetes not on insulin, daily monitoring of fasting blood sugar doesn't do them any good. It's useful if they're sick or they're not feeling well, but they don't benefit from regularly testing their sugar every day. And it can be hard for us to, set aside preconceived notions or beliefs about pathophysiology, or lower blood sugar is always better. Things like that they kind of pounded into us in medical school. But now we have to get away from what we think should work, which is the pathophysiology, and then learn more about what actually does work. And that's what randomized trials can tell us. Read poems, subscribe to poems. We write about 250 of these summaries. They take about 3 to 5 minutes to read, and they are curated for family physicians based on what we know fellow family physicians are doing in practice, the decisions they're having to make, the kind of problems they're facing. It's written by family physicians for family physicians. All of the poems, I think there are about 8,000 now, are summarized in Essential Evidence, so you can find them when you need them. So I think having trusted sources of evidence, not sponsored by drug companies or pharma, an American Family Physician, we've tried very hard over the past 20 years to also make it a very evidence-based journal. We have a grading of recommendations. We've tried to provide more quantitative detail. We don't just say something is better, but we encourage authors to tell us how much better. Using things like number needed to treat or number needed to harm. So I think between poems and AFP, you can do quite well. Yeah, it's been an interesting journey. I have bounced around. I mean, I've been mostly an academic physician. I've also been in private practice, and I started a software company that we then eventually sold, and I continue to work with Wiley, the company that bought us. I think what really helped me was having sort of an intersection of two areas of expertise. I took computer programming classes from when I was 15 years old in 1976. and learning how to program computers, learning a bunch of computer languages, being able to code, being able to create web pages. I created one of the first journal web pages on the internet, on the web, and having that intersection between medical expertise and informatics or computer, programming has been really helpful. It's helped me do some things that I couldn't have otherwise done. So, that intersection doesn't have to be computers. It could be biostatistics. It could be, um, you know, uh, counseling therapy, expertise, or being able to do cognitive behavioral therapy. Having some other complementary expertise, I think, can help you set you apart from other academics and researchers. I especially love my work with American Family Physician because I think the impact that we have as a journal on the practice of so many family physicians. I mean, I think it goes to over 100,000 doctors every month. If just 1% of those 100,000 doctors, 1,000 doctors change their practice because of something we write, that's 1,000 physicians with 1 or 2 million patients. So I feel like it's a real force multiplier for getting evidence into practice.